start Sanofi symposium. And I would like to introduce my dear colleague, Professor Salim Aid, Professor of Medical Oncology, NCI, and his presentation will be sequencing therapies through optimum metastatic colorectal cancer continuum. Please, Professor Salim Aid. Professor Salim.
Muhammad, okay, you hear me?
Yes, yes, Professor Salim, yes.
Okay.
Yes.
Bismillah ar-Rahman ar-Rahim. Dear participants, Mr. Chairman, I'd like first to thank Ain Shams University Oncology Department, and special thanks for Sanofi Pharmaceutical Company to give me the opportunity to share with you this fruitful meeting. My talk today is about, wait, please.
Professor Salim, please share your screen.
Okay. Okay. Here are my disclosures. And as you know, that in the United States, about 30% of patients have metastatic disease at the time of diagnosis. I mean, synchronous metastasis. And another 60% of patients who was diagnosed with local regional disease and received adjuvant treatment will develop metastasis later on, what is called metachronous treatment. And you know that the majority of these patients are unresectable at the presentation time, contributing to the high mortality rate related to the colorectal cancer mortality. Remember that the liver is the most common site of metastasis. You know that the majority of patients with metastatic colorectal cancer cannot be cured. Only 20% are offered this curative intent of treatment, and the aim of treatment in the majority of patients is palliative and generally consists of systemic chemotherapy plus biologic. Recently, there is major advances in the systemic chemotherapy and targeted agent, which expanded the therapeutic option for those patients and leading to improvement in the median survival from 1 year to reach 30 months. But the best way to combine and sequence all of these agents up till now is not known. Why? Because there is a lot of factors which may affect the decision-making when you have already faced a patient with metastatic colorectal cancer. The major of these factors are related to the tumor. I mean, tumor-related factors like resectability. The disease is resectable or not. The disease presented with symptoms and what is the burden of the disease. There is high burden or low burden, symptomatic or asymptomatic, synchronous or metachronous, and the molecular print of the patient, RAS, BRAF, MSI, HER2. The side effects, the side of the primary tumor, right and left side, I know well that is affect the response and already the prognosis of the disease. Also, the site is single site or multiple site, and also the distribution of the metastatic disease. All these are tumor-related factors. Don't forget the patient factor like age, performance status, and comorbidities. Also, the facilities and the availability of the treatment in the treating center and the patient preference. Adding for that, what is your objectives of the treatment? Because it differs from one patient to the other. There is a fighter patient and there is a patient who like to decrease the side effects on the expense of the benefit of the treatment. So this leads to, there is a lot of objectives when you face patient with metastatic colorectal cancer. One of these is you'd like to gain a response like CR or PR to downsize the disease, or just you'd like stabilization of the disease to delay the progression, or your main objective is to prolong the overall survival, whatever the result is. Or just you'd like to control the symptoms and decrease the side effect of treatment. What I mean, just to improve the quality of life. Because when you decide to treat some patient or one patient, these objectives are different from one patient to the other. All these factors regarding the objectives and tumor-related factor and patient-related factor are combined together, make a difficulty in decision-making in first-line treatment. This leads the ASMO to put an elegant stratification of patients for first-line treatment and stratified patients into 4 clinical groups. The first one is the resectable group. You mean that the patient can guarantee R0 resection. Those patients are offered upfront surgery plus or minus perioperative chemotherapy. And the other group of patients are not resectable now, but may be resectable if you have downsizing the disease. For this patient, if we can convert these potentially resectable for resectable, yes, is another group called conversion group. And for that patient, you need to intensify your treatment using doublet or triplet, and of course, using biologic. And the third one is patient who never resectable, but asymptomatic. There is no chance for resection. And the aim of that is to just prolong survival and to maintain quality of life. So single or doublet, and you can use biologic. The fourth group is the symptomatic, but never resectable. And here also you need intensification of the treatment. Here you are looking for symptom control and try to prolong survival. So all of these are clinical group. What about the molecular print of the patient? We know that the RAS mutation is the most common found in colon cancer, and on this result, we can change our treatment plan using anti-EGFR or not, and found it in about 60% of patients with metastatic colorectal cancer. But this recently found that the incidence of presence of this mutation and other mutation are different from one side to the other. If you look to the right side, you will find that the mutation are more and the wild type is less, but on the extent that there is more BRAF mutation and more MSI, but on the left side, you found that more patient with wild type and less patient with mutation and less patient with BRAF and MSI. If we combine both together, we know that patient in the left side group and wild RAS, who are the group who have the most benefit from anti-EGFR. Otherwise, most of the patients will receive anti-angiogenesis. So if we combine both groups together, we will see that only in the first line, 1/4 of the patient will benefit from anti-EGFR. Those who have left-sided and RAS wild, BRAF wild types. But the majority or the rest, 3/4 of patients will receive anti-angiogenesis. So how can, based on the molecular subtype and the treatment group mentioned before, go for first and second line? In the first group, if you have patient with mutant RAS or RAF, it's okay. Very easy decision. You will go for chemotherapy plus anti-angiogenesis. But if you have right-sided with RAS or RAF wild type, yes, less benefit from anti-EGFR, and you go for anti-angiogenic therapy. But in the third group, left side and RAS RAF wild type, you will go for anti-EGFR. In the second line, you will see that anti-angiogenesis is the standard of care. Later on, you can use anti-angiogenesis or TAS or anti-EGFR based on the molecular. But we'd like here to focus on the group in the second line using anti-angiogenic based therapy or other agents. When we look for the data regarding second line, we have a lot of options. One of these options, if you receive BEVA as first line, you can go for another BEVA with a change of chemotherapy, what is called PML study or bright observational study, or you change to another anti-angiogenesis like ramucirumab and RACI trial or aflibercept and velour, or just using anti-EGFR if the patient is KRAS wild type. What is the evidence? We'll choose one example of the three options. The first TML study, the well-known study, in patient receiving first-line chemotherapy combined with BEVA, who progressed on that combination. They randomized patient just to continue BEVA and they changed the chemotherapy versus change the chemotherapy without BEVA. They found significant improvement in progression-free and overall survival. So continuation of BEVA beyond the progression, improving progression-free and overall survival. The other one, if you have patient with KRAS wild type, and this data related to KRAS before the ORAS data, if you use in the second line chemotherapy plus anti-EGFR compared to chemotherapy alone, in this trial, as we found that they used FOLFIRI plus panitumumab compared to FOLFIRI again, FOLFIRI only in patient with RAS wild type, they found here an improvement, significant improvement in progression-free survival, and there is only numerical improvement in overall survival in favor of panitumumab plus FOLFIRI compared to FOLFIRI alone. And the difference here is not that significant. Remember that 50% of those patients receiving anti-angiogen BEVA before. The third option is to change anti-angiogenesis to another, and the well-known RECI trial. There is trial comparing after progression of BEVA combined with chemotherapy, they randomized patient to FOLFIRI plus ramucirumab versus FOLFIRI alone, and they showed significant difference in progression-free survival and overall survival. The other example of changing anti-angiogenesis is using aflibercept. What is aflibercept? Aflibercept is a recombinant fusion protein composed of this Fc portion of the protein and binding domain of part of vascular arterial growth factor 2 and vascular arterial growth factor receptor 1. This compound or this molecule work as decoy just to trap the vascular arterial growth factor A and factor B with placental growth factor. They trap this, preventing them from combine to their cellular receptor, so blocking the activation of this cellular receptor, preventing anti-angiogenesis. The evidence come from activity from this compound in the velour study, the phase 3 study, using aflibercept in second-line treatment. In this study, patients with metastatic colorectal cancer, after failure of oxaliplatin-based regimen, either they use BEVA or not, are randomized to use aflibercept plus FOLFIRI or FOLFIRI again. The primary endpoint was overall survival, and secondary endpoint was overall response, progression-free survival, and safety. And here is the result. The study met its primary endpoint. Aflibercept significantly improved median overall survival from 12.01 months to 13.5 months, and was significant. Remember that there is here the curve after the median diverge and still to separate and not converge. We will talk about this later on. Also, there is significant improvement in progression-free survival. What about? So here we have 3 examples or 4 examples of using anti-angiogenesis and anti-EGFR in the second line. Continuation of BEVA post-progression, aflibercept second line, ramucirumab second line, this is anti-angiogenesis, the 3, and using also the panitumumab as second line. As you see, there is comparable result, but here you can find that there is converge or diverge of the curves by time, and the later curves are converged. But we'll talk about this, as I mentioned, later on. When you compare these trials together, we will find a comparable result regarding the hazard ratio for overall survival, and we found some superiority for aflibercept 20% compared to the other agent. Although this is not a randomized. Remember that this is not a randomized trial, just to not head-to-head comparison, just we data retrieved singly from each trial and compared together. Aflibercept were found to be beneficial across all the groups, whatever the performance status, and either the patient received or not bevacizumab, regarding the benefit in progression-free survival or overall survival. So the benefit is consistent through all the groups. Regarding the toxicity, we found that there is increase in the toxicity, especially the hypertension, diarrhea, and the GI diarrhea, hypertension. And the good news that the majority and the peak of the grade 3 or 4 associated adverse event with aflibercept occurred during the early treatment cycle and decrease on subsequent cycles. So you have to focus on the first 2 cycles during about the toxicity during giving this medication. Expect that the toxicity will decrease later on. After the velour, there is a lot of trial try to confirm or to reproduce the efficacy and safety of this molecule and its efficacy through other subgroup. And this retrospective analysis showed here that aflibercept is effective in all molecular subtypes, RAS wild, RAS mutant, BRAF mutant, BRAS wild, and either the tumor is left or right-sided. Again, in the ozone trial, which is prospective but observational trial, non-comparative, this trial tried to assess the safety and the effectiveness of aflibercept plus FOLFIRI, like in the velour, in patients with metastatic colorectal cancer treated in daily practice. I mean, a real-life situation or real-world situation. And they concluded that the treatment was well tolerable, like what was found in the velour, and already the efficacy was comparable like velour study. Here you can find that the overall response about 17% and the stable disease about 35%. So again, reproduce or confirming the result gained before or the benefit gained before in clinical trial. This is a real life or a real world trials. ASCOP trial is an observational trial. This trial try to assess also in the real world the efficacy and the impact of aflibercept on the quality of life, and the result of this study showed that the treatment is tolerable and also the treatment improves the quality of life in patient compared to the placebo group. This is another confirmation. The third evidence came from a literature. In this, they found that the adverse event of aflibercept in combination with FOLFIRI are more favorable in the real world compared with clinical trials. They found that the most common toxicity was neutropenia, hypertension, and neutropenia and hypertension, but was found less than in the real world, less than what was found in the clinical trial. They refer the causes for that may be due to underreporting in the clinical practice or just improvement in patient management because the physician become more expert or have more experience with the drug. Lastly, they found that the treatment is manageable and they did not found any difference regarding the efficacy or toxicity regarding different geographic locations. So this trial confirmed what was found already in the velour study regarding aflibercept combined with FOLFIRI as second line, but not in the clinical trial, but also in the real world situation. The last point is one analysis was done in the velour study, which is post hoc subset analysis. They try to assess some prognostic factors found in patient receiving aflibercept in the Velour trial. The rationale for this post-hoc analysis came from that they found that after median survival, they found that both curves are separated. So they suspect that there is some group of patients who may have superior benefit and different magnitude of survival gain compared to other groups. What are those groups? After doing multivariate analysis, they found that they stratified patients into two groups. The first one is the better efficacy group, and the other one is the poor efficacy group. This is inside patients with the Velour study. In the better efficacy group, our patients are identified or defined are those patients with non-adjuvant fast relapse, meaning that they did not relapse after or within 6 months of completing adjuvant chemotherapy. So they relapsed after 6 months of completing adjuvant chemotherapy, or patient with performance 0, or patient with performance 1, but less than 2 metastatic sites. On the other side, there is patient with poor efficacy. The other group are those patients who have fast relapser on adjuvant treatment, meaning that they have relapsed during or within 6 months of adjuvant chemotherapy, or patient with performance 1 with high burden disease, or patient with performance 2, whatever the sites of metastasis. So they have different survival between both groups. If we focus here on the better efficacy group, we found that patients in that group have superior gain with aflibercept compared to placebo. And here the median overall survival reached up to 16 months. Remember that the median survival in the Velour trial was 13.6. And also the response rate reached up to 24%. So this is the best efficacy group we have to focus on. And this was shown in this forced plot chart, showing that patients with better efficacy here have consistent benefit either in overall group or BEVA before received prior BEVA or no prior BEVA compared to patients with poor efficacy. So based on this data and what is mentioned before, we can reach a conclusion that metastatic colorectal cancer is a heterogeneous disease, and many factors should be taken into consideration during treatment decision. I mean, tumor-related factors, patient-related factors, your objectives of treatment. Don't forget these factors to stratify, to better stratify and better management of your patients. Remember that angiogenesis play an important role in the progression and the metastasis of colorectal cancer. So blocking angiogenesis by anti-angiogenic drugs is an integral part of management of colorectal cancer. We found it. So colorectal cancer considered as an angiogenic addict. We found that efficacy in the first, second, and third line treatment. Treatment platform of metastatic colorectal cancer subsequent to first line expanding, and there is appreciated role of anti-angiogenic therapy. If you focus on aflibercept in combination with irinotecan, either in the Velour study or in the real-world studies, we found that this combination improved significantly response rate, progression-free survival, and overall survival, as well as quality of life. This combination seemed to be effective either on the right or on the left side of the tumor. It is effective also regardless the BRAF or RAS mutation status. This combination was found it was effective and tolerated either in the clinical trial or in the real life situation. But I have to emphasize that or stress on that. It should be used after. It should be used in its indication. I mean, in the second line, after progression of oxaliplatin-based regimen with irinotecan, mainly FOLFIRI, and especially in patients who had rapid progression on bevacizumab. This is the three indicated scenario or the proper scenario or the 3 indication for aflibercept in the guidelines. The last point I'd like to stress on is in patients who have not fast relapse after adjuvant chemotherapy, I mean non-adjuvant relapser, or patient with performance 0, or patient with performance 1 with less than 2 sites of metastasis. Those patients have superior benefit from aflibercept, as we showed in the post-hoc analysis in the Valor study. Thank you for your attention.
Thank you, Professor Salem Eid, for your elegant presentation. And do you agree with me that aflibercept is underutilized in our clinical practice? So what do you think is the problem to get more familiar with the use of aflibercept in second line after failure of anti-VEGF therapy with BEVA?
Yes, Dr. Muhammad, thank you for this point. I think it is not a scientific point. Yeah, the evidence of benefit is there, as you see. Yes, it's underutilized. There is a lot of factors behind that. Yes, one of this is that concept before about the higher toxicity of aflibercept, but as you see here, that just only in the first and 2 cycles, and it's manageable already. And already it is very similar to BEVA, RAMO, and other anti-angiogenic. Yes, there is less promotion for the drug, and there is only just 1 clinical trial, and as you see, randomized clinical trial, the other just confirm it and to confirm its efficacy. But if you look to the data and you revise, yes, it is underutilized and should have more focus and should be utilized. And I think in the clinical practice, most of us use post-progression BEVA rather than shift to the other. But
yes.
For me, I'm not with that, at least now, because we have at least to change the mechanism of action. You have to shift, like to shift another chemotherapy, also to shift to another anti-angiogenesis, because you couldn't know where the resistance came from.
Yes. Thank you, Professor Salem Eid. And to conclude your presentation, can you give us a quick conclusion? Who are the best patients to be giving aflibercept?
Yes, I have to stress on 2 points.
Yes.
At first, the indication of aflibercept. Yes. First, at least it is the second line. Post-progression of oxali, whatever you used or not, BEVA, it is effective and combined with irinotecan-based regimen, and best to be with those who have no benefit or rapid resistance to bevacizumab. This is the indication. When you receive it, there is 1 group of patients who have better survival than others, and we have to focus. The first one is the patient who did not have fast relapse after adjuvant treatment. I mean, more than 6 months after adjuvant, there is the history of the patient. The other one is patient with performance 1, whatever the site of metastasis, and patient, performance 0, and patient with performance 1 with low burden disease. If you focus on or stress on these 2 points, this is the best way to have the maximum benefit of aflibercept.
Okay, thank you, Professor Salem Eid, for your elegant scientific presentation.